Patellofemoral disorders, there's two approaches. There's a traditional approach and there's a biomechanical approach. Traditionally, I don't know if you guys have heard the name Jenny McConnell or McConnell taping, okay? She's an Australian physical therapist. About 15, 20 years ago, she was one of the first therapists to really start looking at the kneecap itself. People had a lot of chondromalacia or patellofemoral pain. They didn't even call it patellofemoral. And anytime anyone had pain in the front of the knee, they just called it chondromalacia. Now the problem was we didn't really figure out exactly what was going on there. They assumed that the articular cartilage underneath the knee was really getting irritated and injured, and that was causing the pain. And yet when they went in and did arthroscopic surgery, there weren't any bad changes in the cartilage underneath, so that wasn't causing it. So what she started doing, she said, well crap, I'm going to take the kneecap in place because it doesn't look like it's in place, and it relieved a lot of pain. And then they started doing a lot more studies on it. Why does that help out at all? And they started finding a lot more information. It's really over the last 20 years, 15 especially, that they've gathered most of their information about a lot of the patellofemoral involvement and really what's going on there. But one of the things that she keyed in on is a lot of these people with kneecap pain would develop a tilt, or they would develop this lateral deviation, or they would even develop a little bit of rotation. And so by actually taping it in place, it would decrease some of the stress. Typically what you see when you go into an orthopedic surgeon with a complaint of kneecap issues, they'll take an x-ray, they'll take the normal straight-on view, they'll take the side view, and then they take what's called a merchant view. They put you in about 30 degrees, and they take the x-ray straight up through, or I'm sorry, straight down through the leg, and they look at how that kneecap sort of sits in your trochlear groove. So that femur comes down and ends in a groove just like you have in your knuckles, and the kneecap should pretty much sit right in the middle. And what they're looking at is how it's tilted. So if it's significantly tilted to the outside, typically that indicates that the deep fibers of the connective tissue, the lateral retinaculum, the deep fibers are that IT band attachment, are very, very tight. And so they're locking it down and pulling it over. If the whole lateral structure, your lateralis, the retinaculum, the IT band are tight, then you get this lateral deviation. If you have any bony anomalies, like the bony structure, let's see, we will talk about that in a minute, but the bony structure, normally if you're looking at those condyles, we naturally have a larger or higher condyle on the outside. So in our design, it was there to act like a buffer, a bumper for that kneecap so it wouldn't dislocate. Some people are born with a shallow groove, so they don't have a real high buffer, very shallow, and it's very easy for that kneecap to slip out. Those are the chronic dislocators that you might get into. Typically they're going to be female. Those are the ones that most likely are going to end up having surgery for some sort of patellar realignment issue, okay? Because it will just go out when they sneeze. So, again, you're looking at some of the rotation. You're also looking at even the tilt, the forward and downward tilt, because if you have an injury to the quad and it tightens up, it's going to tilt that kneecap up. Typically, if you have a lot of chronic tendonitis, it's going to tilt down, very restricted, very painful. That's almost like a jumper's knee type of deficiency. If we have that imbalance of the medialis versus the lateralis, that's going to create that outward pull. The VMO is not going to be able to control it. That can contribute to a lot of pain as well. So again, those are the traditional approaches, and a lot of the things they looked at, I don't know if you guys have heard of Q angle. So when you take some alignment, you have some people stand. This natural valgus alignment is called a Q angle. Normally we have that. You have some people who tend to be a little more bow-legged, and you're not going to have a very good Q angle there. We always have some to some extent. Normals, males are about 13 to 15 degrees of angle. Females are typically 15 to 18 degrees. They have wider hips, so they're going to have more of this L-shaped alignment. It should be between that 13 and 15. If it's outside of that, they're at risk for some patellofemoral problems. VMO deficiency, weakness there. Okay, people who tend to be too tight here. VMO can be deficient, they're going to have problems. Lateral retinacular tightness. Retinaculum is a tissue, a connective tissue that you have on either side of the capsule. The medial retinaculum is a very, very common place. It's very highly innervated, very painful structure when the knee gets irritated. Patella alta, it's a name you might hear. That's when what they do is they look at the length of the kneecap and the length of the patellar tendon. Normally, they're the same. Okay? If someone has a patellar tendon that is 20% longer than the length of the patella is going to be riding high. It's sort of sitting on the upper regions of that groove, so it's much easier for it to come out. Though, again, it tends to be in a female population. They're going to have a hypermobile knee, very common to dislocate.